and so these are cross sections like this. So that's again, this is the left side. So the right side of the screen is the left side of your body. So left ear, left eye, nose, right eye, right ear, back of the head. And the CT scan is best at looking at bone and hair. So you're not going to see you're going to see very little brain anatomy or brain resolution. It's really looking at bone. So all this white here is bone. And then you'll notice, just like a honeycomb, look at the normal side for a minute. It's got a lot of black in it, and that's all hair. And so this is the temporal bone, and we'll talk a lot about that in a minute on the affected side. And so just as a first pass, it should be roughly symmetric, and you can see normal skull here, and that's what we would call an expansile mass of the right lower temporal bone, which is right here.
Yeah.
You know, if you were to ask a radiologist, you know, what could this be? They would say hemangioma, or hemangioma.
Yeah.
But then they would start to list sort of more esoteric things, just because that's their jobs. Like myeloma would be something that they've mentioned on the report.
Yeah.
And we'll likely send a marker for that, but I would highly doubt it's myeloma. It's very stereotypical for a angio. And you've probably done some online research or talked to some trusted colleagues already, but these are not that common, and they can really occur anywhere in the skull. You have hemangiomas that occur in the brain, and you have hemangiomas that occur in the skull and other places. Let me show you a little bit more about that. This also, and this is you looking out. Actually, let's start this. This is you looking.
There you go. Perfect. Thank you.
This is you looking sideways. Okay. So nose here, your mouth is down here, forehead, top of the head, back of the head. Again, everything that's really black is air. So we have air-filled spaces in the skull. This is a funnel sinus. This is another sinus. And I'm going to come out to that affected side here on the left. So now we're kind of out here now. Okay. So this is you mentioned TMJ. So this is the connection of the jaw with the skull is right here. So it does get very close to that. It's not involving what we call the mandible, because it's a separate bone. But the intersection where the mandible, almost a socket where the mandible hits the base of the skull, that is very, very thin, possibly involved there. So that's one issue that we'll talk about.
So that could potentially be causing some of the pain?
I think it's causing some of the pain, and it also has implications for, kind of as a surgical detail, if we go that route. Okay. The other thing you'll see here, all of this, again, this honeycomb appearance, that's the normal appearance of what we call the temporal bone. So on me, that's sort of right here. And I'm going to show you one other view of that, which brings up another, just an anatomical point. This is you looking straight out of the screen here. Left eye, right eye, top of the head. So now the cut is like this. Okay, we call it coronal view. You're looking right out of the screen here. Again, we're going to go backwards here. That's what I just showed you in a different view. So here's that mandible. Here, as you can see, that's the normal joint. So you see how that white is, that bone is very white. It's very strong, and you're just seeing some of that joint being eroded there. Not the mandible itself, but the joint itself, the bottom of the temple bone. As we go back here, I want to stop here for a second. Okay. This is, let's look at, mentally Photoshop this out for a second, if you could. This is the ear structures on the left ear, okay?
And thank you, by the way, for taking the time to explain all this.
Yes.
Of course, no, we like doing this. So.
Great.
If you're about to fall asleep, just let me know.
No, not at
Never.
all, not at
Never.
all. We both have a science background, so it's interesting.
So here, if you were to put your finger in your left ear, here's your ear canal on the left, okay? Now, at some point, that cartilage ear turns into a bony ear canal, and which is right here. Now, in that, so you've got the eardrum here, and then you've got, on the other side of the eardrum, you've got these small interlocking bones that provide the conduction of sound. And that's these little, they look like they're floating here, but they're just connected, very small. These are the small ear bones. Now, let's flip over to this side again. So, here are those ear bones. I don't think the bones themselves are not affected, but the roof of this inner, what we call the middle ear, I'm not sure it's unaffected.
Yeah.
So again, here's the normal roof. Now, if I look at this in the operating room, and we do this a lot, everyone's roof of the middle body, it's very, very thin in almost everybody. So it's thin at baseline. So I'm guessing there is some involvement. I can't rule out that this hemangioma, or let's call it hemangioma just for discussion right now, I can't rule out that that's not involved here.
Would an MRI better show that?
Probably not.
Probably not.
CT, in
It's
fact,
the bone.
yeah, MRI will look for a few different things, but this is actually a great study to start with because it's such a bony lesion, and CT is really good at looking at bone. When we think about, in terms of how to manage this, there isn't a great medical option. You probably read that already. There's not a great radiation option.
Yeah.
In other words, there are not really many non-surgical options,
Yeah.
as in done.
Yeah.
So we're looking at either, now hemangioma, these, you've noticed some asymmetry for a while. It's likely this has grown incredibly slowly over time. And if you got a CT scan in a year, it'll look possibly measurably bigger, maybe the same. It's just now you're going to keep noticing any growth because it's of a sufficient size.
Yeah.
So if you say, hey, look, thanks, it's going to grow slowly, really busy right now, I'm gonna put this off for a while, that's fine. And you wouldn't be putting yourself through any risk. If you say, hey, look, at some point I'd like to have this removed, and just to have this taken away, it likely would involve me, but probably 2 additional specialists. One would be a specialist who deals with these ear bones. His name is Alex Bean. I've spoken to him already. B-I-E-N, yeah. And the other is going to be an oral maxillofacial surgeon. I have not talked to him yet, but a guy named Paul Tijuana, T-I-W-A-N-A, who's got a regular reputation here. So Bean would just help if we need to do anything with this and anything with those ear bones. And I would want Dr. Tijuana to help us if we need to do any construction of this joint here.
Makes sense.
Yeah.
But the 10,000-foot view is we remove this. Let's say if this was up here, we remove this all in one piece, and we then reconstruct and recontour the skull with essentially a synthetic. There are a couple of materials we use. Because this is, we would remove some of this in one piece, and then we'd have to do some finer scale removal down here, right above that those ear bones, and then also right above the joint apparatus.
Got it.
So basically in that area, it just gets a little bit more complicated.
Yep.
Yeah.
Very doable, it just requires a little more nuance down there. In those 2 spaces in particular, this one here, this is really what I want to show you most, is this here, and that one right here. I'll pause there and see if you have any questions from what we've gone over.
From what I've read, most hemangiomas are benign.
Yeah.
Do you think?
This is very
It's
likely to be benign. Yeah,
Okay.
I have not encountered one that isn't. Again, they come to attention just because they're palpable. They're palpable. Some grow in a different direction. So yours is growing a little bit in and out. Some grow just out. Some grow just in. So you're almost symmetrically expanding the inside of the skull. We do have to shave a little bit of hair.
Oh, I figured. Now I've got plenty of hats. I've got a couple wigs. I've got everything.
There are a few different ways to repair the skull here. One is with essentially it's a fancy plastic basically called PEEK, polyethylene ketone. There are surgeries where we remove parts of the skull. This is not you, but and then there is a defect in her, and we come back in a few months and we repair that defect. In those cases, we take a fancy CT scan, send it to a company, and they remodel that defect and send us that part, and we then put it back in. I've also done where this is not a case where we want to leave a defect. We want to make a defect and repair the defect in the same setting. So it's a little bit different than what's done more commonly. And we have contracted with a few companies where we model the area to be removed three-dimensionally with a fancy CT scan, and we do an online phone call, and we're using essentially CAD, photoshopping, over to do this, and we actually talk to the engineers real time over like a Skype call or something like that.
Yeah.
And I've done that. I've done it quite a bit when I was board here, and then I've done it here a few times. It's never 100% perfect because we may remove a little bit more than we think, and anything that looks abnormal we want to remove. But it's pretty good, and we will likely do something like that, where then what we take out is then replaced with this essentially fake skull. The other option, which frankly it's an oldie but goodie, it's really kind of gone out of style a little bit, is just titanium mesh. It's a very hard metal that's like a lattice. It's very firm to provide structure and protection, but just bendable enough to allow us to contour it. I think for someone young and a female like you, we would probably want to go the former route. It's a little more custom design, and we probably would do that. And they need a few weeks lead time to design the implant and send it to us.
Like it how it's, I'm assuming it's almost like there's a piece here, it's almost missing, it would normally be here.
Yeah,
Bit of the
this is exactly right. So
temporal bone.
this is this temporal bone,
Right.
and this is a very on the left is a very common.
It almost looks like it just got.
It's replaced, yeah.
Yeah.
You're exactly right. This is a pretty common picture of these are your balance canals, your cochlea, right here, your hearing, balance and hearing apparatus are here. All this is just error, and you can see, not that it's always a straight mirror image, but
Right.
some of that has been replaced on this side by, like this portion has been replaced by the.
Right.
That error is a very safe space to work in and drill around.
Because there's not much there, right? That makes sense.
But we do want to make sure that this is protected. These are the middle ear bones.
Yeah.
So this gray area, this is we call it the internal auditory canal. It houses two nerves in particular. One is what we call the vestibulocochlear nerve. It's a balance and hearing nerve. So the hearing part goes, this is the cochlea, so this is the hearing organ for the right side of for your right side. And then here it's like a Olympic ring looking tri-ring structure. It's a semicircular canal, so the balance part of that nerve goes there. The other nerve in here is the facial nerve. Now, it's close-ish to where we would be working, but not at significant risk, but we would be monitoring for that. The facial nerve, it deals with not the sensation, but the movement of the muscles on the right side of the face, not the left, just the right. You have a left and a right side.
Yeah.
We usually think of face as this, as smile, but face is also closing the eyelid. So the really important function of that nerve are making sure the eyelid closes and the surface of the eye is lubricated well and protected from, like Oklahoma, it's windy, as I'm finding. And the second allows you to kind of turn that, so there's a ring of muscles here that it contracts and a ring of muscles here that it contracts. So that's a facial nerve, and you've got the hearing nerve and the balance nerve. Those are the three nerves that are not bony structures that we would be sort of checking, making sure that are fine during surgery. And there are ways, we do what we call neuromonitoring. There are ways of monitoring that function of those nerves during surgery. We do all that.
Okay.
So the next steps would be, again, MRI. We would likely want to get the CT scan that's compatible with a company that would then, we would sort of create a virtual defect, that we would do that together before the surgery, to understand what we'd be removing so that you can design something to be replaced there. And then I would want you to see Dr. Bean and Dr. Tawana Bean, I've spoken to you, you've spoken to him about you already, since one I have not spoken to him. I would likely speak to them, and then they would call you to set up an appointment.
Okay.
They're both, like, right, Bean is over there, and one is over there, so it's all
Oh.
pretty co-located.
Great.
So this is a type of scenario where, you know, you take an MRI, take the, you know, the supercharged CT scan, or whatever it's called, and then, kind of come up with a game plan, but until you, like, actually get in there, you're not necessarily, I guess, what are the, you know, what?
I think you're 100%
are you gonna,
right. That, you know, for us, almost every operation is like that,
Right.
where we do an incredible amount of planning and thinking, and then what we find at surgery sometimes alters those plans.
could be different.
Yeah, I think for this, it would be, how thin is that
Right.
covering of the middle ear bones? How thin is that floor above the narrow joint? And making sure that's a little bit imperfectly estimated on the CT scan and better visualized.
Right, because basically you're gonna have kind of an idea, but there's, you know, the precision on that is probably not that great, is what I'm hearing, until you actually get in there and see
Yep.
what's going on. Right. I mean, what I'm hearing overall is that the prognosis is quite good.
I think it's fine for this.
Yeah.
Great.
Yeah, it's just, there's an upfront investment of just the surgery, it's not tiny, and there are some nuances which I mentioned to you, and, you know, I think even though you're young and very healthy, it is a big tax on the body, so even though you're technically asleep and not doing anything, the body knows something big is happening, so, after surgery, you might feel unexpectedly tired and fatigued, and that's really common.
Sounds like everyday
It's
grief.
every day. I mean, it's
The other thing too
fibromyalgia.
is the bone doesn't feel pain and the brain doesn't feel pain per se. The lining of the brain, it's a leather covering called the dura. We will be manipulating that. That does have extensive pain sensitive tissue. And the second is the soft tissue.
Yeah.
So overlying right in this area, you've got scalp, but you've also got the temporalis muscle,
Yeah.
which sort of sits like this, and we've got to manipulate that and move that out of the way. That creates discomfort. We'll give you pain medicine support, but I'd say there's all the pain from the surgery generally comes from just the soft tissue stuff.
Makes sense.
Do you think it's likely that that's placing some kind of like pressure internally a little bit?
Some, yeah. I'd say
On the
not a
brain?
lot, but some.
A little bit.
What
Yeah.
could it be affecting?
Nothing in the brain.
Okay.
The only thing I would, you know, if you came in saying, okay, I've become increasingly imbalanced or dizzy, I would think that could be relative to necrosis in certain canals or maybe hearing. Dr. B may want to get a hearing test.
She's complaining of headaches for a long, long time.
I think this could contribute to headache, sure. I think so.
But probably more likely the headaches than anything else, but there could be some TMJ issues because of that joint.
Or
Yeah.
at least feeling from
Balance.
that area. It may not necessarily be
Right.
TMJ itself,
Right. But there
near
could be
there.
some there.
but I mean, I went and got my teeth straightened because I thought that's misalignment of my jaw or my teeth was the issue.
I'm gonna have you just open and close your mouth. Just I'm gonna feel your and close. I mean, the mandible does shift a little bit when you do that, but yeah. So I think it'll be helpful to have oral maxillofacial surgeon who does that job work. Just may need to do nothing, but just really sort of it's sort of just a case.
Okay, so the
Yeah.
timeline in terms of getting it done is sort of like whatever she wants to do.
I think so.
Essentially. Okay. And then once you make the decision, okay, it's time to move forward, then how long does it take for everything to happen approximately?
I'd say again, there's the next imaging steps, which are pretty formulaic, and then there's the appointments, and then there's just synthesizing everyone's surgical schedule, but that's really not that hard.
Okay, so you're talking something that'll be on the order of months, but not.
Probably, you know, really, but that pace can be determined by you in some way,
Okay.
which I think we just move along at a kind of a not breakneck, but also not leisurely pace, something in the
Right.
middle. It'd be probably several weeks.
Okay. To get everything kind of planned out, and then you do the surgery like in the next few months or
I think so.
something like that. That's
Yeah.
how it would work. Okay. That kind of helps me give me an idea because it just, I don't know, it's a new experience for me. So.
Yeah, you and me both. wanna get started on this and get it done.
I mean, this is, it's a little bit, I guess, at least for now, I think it's a little relieving, assuming nothing bad is found down the road. But I think it's pretty consistent with what we expected, so.
Yeah.
It sounds like, okay, that's, overall, it's, if it was 100 years ago, it'd probably be a bigger problem, because you can't really stop it, right? But, yeah, we had kind of thought that from what we had been able to figure out, it seemed as though this has probably been there for a very, very long time.
Yep.
And it's just a matter of solving a problem now, more so than anything else. So,
Well, I appreciate the organization that you have in this. Is that all related to this, or?
Yeah, yep,
Yeah,
I've
that's
got
tremendous.
my health files,
Yeah.
contact information for a Mayo Clinic. I went there to, get a check on my diagnosis of fibromyalgia. They also added on chronic fatigue syndrome. They did take a look at my ears. I had a former diagnosis of Meniere's. They reversed that and said, no, there's no damage going on, it's actually okay. So they did all the tests for that. At that time, that was in March of 2018.
they did not do a CT scan.
They did not do a CT scan. No, I know that because I don't have that information.
Nicole's very organized to begin with, but there's a
Yeah, here's
very
the-
extensive amount of, stuff that she's tried to do over the years for these nagging medical issues.
That's really impressive. When they took
Yeah.
this here. Well, this is a great hearing test. You've got word recognition scores of 100%. Yeah, no, this is a great baseline. He may want to get another one.
Oh, of course,
Yeah.
that makes perfect sense. I
Yeah.
mean, this
Yeah.
thing
See if it's changed.
has probably changed since then, and I think that's great.
There's probably more data on you than most patients ever met.
Yeah. I mean, I've got chest scan, got all of that. Various doctor reports, their clinical notes whenever I can get them. So, yeah, this is basically everything I have on my medical health.
I mean, how many of these things do you see, assuming that it is
Mhm.
We see a lot of them that don't need intervention, so, a lot of these are picked up incidentally. So not a palpable mass of your size. Let's say someone gets an MRI or CT for something else, and they show up.
What's that?
Yeah, so we see a fair amount of those. In terms of those that need surgery, I'd say fewer than 10 a year for sure.
Wow.
Yeah. And that would really be most big centers. It's not hugely common.
Right. Yeah, it sounded like it was pretty rare.
Bony lesions are hard to get. You might have heard the term frozen section, which means we're removing something. We send a piece of it to the pathologist while we're operating. They look at it, call us back while we're in the operating. It's very hard to do that with bony lesions because it takes a specific kind of preparation.
Right.
So the notoriously can't do a lot with it.
Right.
So that if it were something else, we would likely do that.
They've got to put it under the microscope. So.
We have a pretty clear path of what we're doing.
Yeah, next you have a couple of appointments, a couple of scans, and then we've got that. We'll proceed to sort of make a synthetic replacement, and then at the same time be thinking about times where the surgery will